So now we go to our keynote speech. I'd like to introduce Sita Dio. Sita has a master's in public health and an MSW. She was the, I'm going to try to find my notes. She was the state director for NAMI in Tennessee for 6 years, and now serves as the state director for policy and advocacy for NAMI. Sita taught me NAMI smarts and has made me smarter. And I always enjoy working with her and her colleagues, her partners in crime. So, Sita, thank you very much.
She was to shoot us before we get started.
Before it gets too bloody? All right.
Good morning, NAMI. Good morning. I'm going to get suited up here. Hang on just a sec. I hope. Although I work for our national office, I live in Nashville, Tennessee. And in Nashville, we know how to snuggle up to a mic. So let me know if you can hear. Can you hear me in the back row there? Okay. As Mark says, I have a slightly confusing title. I'm the Director of State Policy and Advocacy for NAMI at our national office. And so I'm working for you out here in the hinterlands, bringing what you do, all the wonderful work you do, all the challenges you face, all the help that you need. I'm bringing those messages from the community back to our office in DC. And then we work with what you give us in order to churn out tools and resources that you can use. I'm absolutely delighted to be with you today because this is an opportunity to listen. I love to listen, so I'm going to be with you throughout the day. Please come up to me and talk to me about the good, the bad, and the ugly. You know, the things that are going well in your life, the things that NAMI is doing well, the things that Washtenaw County is doing well as the challenges that you face and any bright ideas you have for resolving those challenges. Because as NAMI, we take our cues from the grassroots. Most of the brilliant stuff that we do at the national level came from you. I'm just saying. I bring greetings from Mary Giliberti, our CEO, and all of the national staff. I have to say, after I'm a very long time NAMI member, I'll tell you in just a sec how long time, but it's been an absolute privilege to work on the national staff, to work with such dedicated and skilled people who really do wake up every morning and sometimes in the middle of the night thinking about you and about how to make your lives easier, how to build better lives for everyone who lives with mental illness. Actually, I'm second generation NAMI, my wonderful mother-in-law having turned to NAMI in the late 1970s in Madison, Wisconsin, when her son was diagnosed with schizophrenia. He's well now, my brother-in-law. He's happily married, he's fully employed, he has a stepson, and he's happy. But there were some rough years, 15 rough years, where he was psychotic on the streets of San Francisco, homeless. We feared for his life. At that point, my mother-in-law turned to NAMI. They listened to her, they opened their hearts, they opened their homes. She wept, she was angry, she was comforted, and then she herself became an agent of healing and change for others. That's the NAMI way, we pay it forward. So when mental illness emerged in my 3-year-old son, I turned again to my NAMI friends. Patiently, they listened to my weeping. They helped me transform my grief and fear into hope and healing. And I'm delighted to report that my son, now age 25, is an absolute poster child for early intervention. I'm going to talk about early intervention, but I believe it down to my muscles because at the age of 25, he's now in Madison, Wisconsin. He grew up in Nashville, Tennessee, but moved back like salmon swimming upstream. There's a lot of stream analogy here. to Madison, Wisconsin, where he's at the University of Wisconsin in the biochemistry department pursuing a PhD. My son, who couldn't pick up his clothes on the floor of his room, just organized a conference for 225 people. That was an absolute roaring success. So I'm just saying that if we identify, if we stop, if we turn away from our fear and turn toward the issue, lean in, get help early, and work with each other, there's immense potential. We're in a time of change in the mental health world. So Roger these days is smart and funny and kind and a friend to his friends, particularly his friends who live with mental illness. Again, that's the NAMI way. We pay it forward. So as you can see from the blurb for this session, I'm taking my cues from the history of Michigan. This state has a laudable culture of exploration, of innovation, from the French voyageurs to the great inventors and entrepreneurs of the early 20th century, to the resurrection, the exciting resurrection now underway in Detroit. Our extended family has a cottage in Pentwater. Anybody know where Pentwater is? Yeah, woohoo! So I associate Michigan with blissful summers, paddling the rivers, jumping in and screaming and running out of Lake Michigan. And so I love your state, and I'm delighted to be back here. So I hope you're going to indulge my river analogy as we proceed through this talk. I promise I won't bludgeon you too hard with it. The American health and mental health sector is undergoing a time of turbulent change, and Michigan is in deep water. As with all crises, we encounter snags that can upend our lives, but we can also seize opportunities, currents of change that can propel us toward our ultimate destination. So during our time today, I'll describe threats, I'll describe effective opportunities, I'll describe strategies that can move us forward to reach our goal, and I'll call us to action by laying out a few things that we can do collectively and individually to move forward toward a brighter day when everyone who lives with mental illness will be able to live a full and fulfilling life. But before I dive into these threats and opportunities, we want to learn from you. So I know Tyrone showed you your index cards. Rather than saving them for the end, what I would like you to do is to take them out right now and tell me two things. I would like you to write down one problem or challenge that you see that you have recently experienced in yourself, in someone you love, in somebody that you work with. It has to do with the mental health system. So write down one challenge, and then for extra credit, write down a strategy that would fix the problem. So the challenge might be that you couldn't find a place to live that was affordable in a neighborhood where you felt safe. Or maybe you couldn't find a psychiatrist or a therapist who took your plan. Or perhaps you couldn't find a treatment provider who understood your culture. Or, one thing that got in the way of recovery for somebody that you care about or for yourself. So just take a few minutes now. And Tyrone is walking around, so raise your hand if you need one of these cards. What's going to happen with these cards is that Mark will collect them, and he's going to sort them, and then in the practicum that we have later on in the morning, we're going to actually dive into these problems that you're laying before us and do some strategizing and come up with the beginnings of a plan for how we can advocate for change. Yeah, I want to walk around and let's just see how people are doing.
Does anyone else need a packet with the cards? We have some extras here if you do.
If you don't feel like writing, that's okay. In NAMI, we always say you can pass.
Yeah.
But we're really looking for your wisdom.
Yeah, I'm just going to do it like the, and if you want to put money in here, that's fine. We like, I wish I had my tambourine. Did you
Yeah, there
bring
you go. This does feel like church. I feel like there should be an offertory or something playing while we're going through this. I'll wait just another minute, and then you can keep writing while I keep talking. Some people have a lot of ideas, which is fabulous, or a lot of problems.
Next time we do this, we should have music.
Yeah, we definitely need music. So thank you, everybody. Those of you who are still writing, keep writing. And we can collect the cards at the end of the session. So now let's take a look at mental health services in Michigan. I'm going to take a look at the stats in Michigan, the numbers in Michigan compared to national figures. You've really got some deep challenges. The prevalence of mental illness is higher in Michigan than in the nation as a whole. So 19.8% of the Michigan population has any mental illness, compared to 18.2 nationally. The prevalence of serious mental illness is 4.7 in Michigan, compared to the national rate of 4.1. Psychosis was the 6th leading cause of hospitalization in Michigan. It outranked cancer and heart disease. And Michigan has a far higher rate of psychiatric hospitalization and readmission than the nation as a whole. Suicide here is a really serious problem. 4.5% of adults seriously considered suicide, compared to 3.9% nationally. And in 2009, suicide was the leading cause of injury death statewide, which is an alarming increase of 41.6% since 1999. Shot up. Depression among youth is higher, 10.2% in Michigan compared to 9.9% nationally. And 12.8% of Michigan's children are identified with serious emotional disturbance, compared to 10% in the nation as a whole. And yet, despite the high need, Michigan's public mental health system only provides services to 25% of the people who live with mental illness. 3/4 are not served by the public system. Now, some of those people are served by the private system, but some of those people are out there needing help. 41 out of 83 counties, mostly rural counties, are designated as mental health professional shortage areas. Some, the shortage is dire, like there isn't a psychiatrist anywhere in sight. You've got to schlep down to the big city. So within this context, there are some major threats, even to the inadequate services that exist now. The first problem is the eroding state mental health budget. You're in the river here, while I'm standing on the edge, so correct me if I'm wrong, but it looks like state mental health spending was drastically cut from $281 million general fund dollars in 2013 to $97.5 million in 2015. Mental health funding seems to have been maintained this year, but the demand has increased. Now, some of that cut was actually just a shift to Medicaid in order to draw down the federal match. But we know in NAMI that not everybody who qualifies for Medicaid gets Medicaid, and those safety net dollars that are administered by the state mental health authority are absolutely critical to fill in the gaps. But by shifting those dollars, the plan was that mental health and substance use treatment would be covered for all in need, either by Medicaid expansion, by traditional Medicaid, by private health insurance, including the health plans on the marketplace, the ACA health plans or Obamacare health plans, by Medicare, the VA, or other sources. But few plans survive their collision with reality. I would venture to guess that most of the people in this room know someone who has fallen into the stream, who can't get the intensive mental health treatment, housing, or other supports that they need, even though they're in desperate need. So how many people in this room know somebody like that? Can't get the help they need? Look, folks, it's a lot of hands. So as NAMI members, we know from painful experience that the intensive multidisciplinary wraparound services that are often necessary for recovery from serious mental illness are not adequately covered by private insurance. That's an understatement. Some people earn too much to qualify for Medicaid, and yet the qualified health plans under the Affordable Care Act may not be either affordable or available. As a result, our people wash out into the deep end, surfacing in emergency rooms and hospitals, on the streets, behind bars, and most alarmingly, in the morgue. Now, the Healthy Michigan Plan, which was supposed to be the safety net, is under threat. 590,000 Michiganders stand to lose coverage by next spring if the Michigan Plan amendment is not approved by the Federal Centers for Medicare and Medicaid Services, because the Michigan legislature wrote into the law that the plan must be amended or it will expire in April of next year. And yet there are some big problems with the proposed plan. First, it requires people with incomes above the poverty level who have been in Healthy Michigan for 48 months or longer to either purchase an Obamacare health plan or enroll in traditional Medicaid. Those who enroll in Medicaid after this 48-month period face exorbitant out-of-pocket costs. They will have to pay 3.5% of their income as a monthly premium and cost sharing of up to 7%. This population with serious mental illness is considered by federal law to be exempt from this. Nothing can go wrong, right? But we know that there will be people who fall through the cracks, who will be subject to these exorbitant costs, who live in poverty. And if you live at 101% of the federal poverty level, you know that you don't have any cash to shell out for health care. So this is a bad precedent to set for Michigan and as an example for other states. This is the first time we have seen this kind of cost sharing of this magnitude in a Medicaid expansion plan. Secondly, ACA health plans vary in terms of their benefits and their out-of-pocket costs. It's not clear whether people who are leaving Medicaid for Medicaid expansion for the qualified health plans will get the guidance they need to buy a plan that meets their health and financial needs. If you know somebody in this position, help them get in-person assistance from the ACA. You go on healthcare.gov, it says find local help, you click on there and it pulls up the in-person, face-to-face assisters. NAMI is part of the National Disability Navigator Resource Collaborative. Doesn't exactly trip off the tongue, but it's a really good group of folks, across disability group of people who have developed a whole library of resources for navigators, to help navigators get people into the right kind of plan. It's at nationaldisabilitynavigator.org. You can see that on the screen there. But back to Medicaid expansion, NAMI and NAMI Michigan signed on to a letter from a task force of advocates in Washington, D.C., expressing concern to the Health and Human Services Secretary, Sylvia Burwell, about these provisions of the amendment. The dilemma is, if this amendment goes forward, it's high cost and inadequate care, potentially. If it doesn't go forward, 590,000 Michiganders stand to lose coverage unless the legislature acts. So who's got to act? Us. We've got to get to those legislators and go, you can't let this happen. We have got to go to our administrative officials at the Medicaid, the state Medicaid authority, and say, you can't let this happen. This is not acceptable. The chances are that CMS will not approve this waiver, and then we've really got to get into action in order to save Healthy Michigan. Add leadership change to the threats of budget cuts and disruption in Medicaid, and we come to the brink. I hear that people who have served the mental health public for decades are retiring or moving on to other things. So with them goes the institutional wisdom gained from the long journey from then until now. With them also go working relationships that many of you have established over the decades, and that you've worked together to forge some of the best practices that we're going to hear about in this conference. But changing leadership also represents a major opportunity. New leaders will bring in new strategies and skills and technologies, but this is where your voice is crucial. Offer NAMI as a resource to policymakers. March right up to them as soon as people get into office at the county level or the state level or in the administration or in community behavioral health. March right in, introduce them, say, we're NAMI. We are the voice of lived experience. We are people who live with mental illness in ourselves or in someone we love, and we're here to help. A politician recently pulled me aside and said, you people at NAMI don't realize what power you have. You bring health issues to life. We need to hear from you. So don't be afraid to press for what you need. When we're dealing with budgets and policies, it's abstract, but when you walk into the room, it says to us, this is what I'm working for. And when you give us the goods, what it looks like on the ground, we listen and we incorporate it. So as any grassroots organization, individually, we are weak, we feel overwhelmed, we feel stepped on, but pulled together, knitted together, we are unstoppable. That's our movement. Politicians, government officials, and community leaders need continuous feedback from us, the customers of the mental health system. They need to know about your personal experience, what you went through, what helped, what hurt, what would have helped, and what will help others. Michigan has a tradition of stakeholder involvement that must be protected and nurtured as the leadership changes. A very promising opportunity has opened up this week. It was really good that I came like today rather than Monday. Michigan was one of 24 states to receive a grant from the Substance Abuse and Mental Health Services Administration, or SAMHSA, to implement the Excellence in Mental Health Act that was sponsored by your own wonderful Senator Debbie Stabenow. I'll tell you, let's give her a round. The Certified Community Behavioral Health Planning Grant of just under $1 million was awarded to the Behavioral Health and Developmental Disabilities Administration. Do you all call it Buddha? I love it. I'm going mindfulness, balance, that's all good. In collaboration with the Michigan Association of Community Mental Health Boards and the Michigan Medical Services Association, or Medicaid. This year-long process prepares the state for a 2-year demonstration project to develop 10 certified community behavioral health centers around the state that will serve adults with serious mental illness, children with serious emotional disturbance, and people with serious substance use disorders. To be certified, the centers will need to provide a variety of services that you see listed here. I'm not going to go down through them, but you'll notice that these are the things we need. This is a plan to deliver the things we need, including integrated primary care, so that you can walk into one of these certified centers, and no matter what your problem is, whether it's your diabetes or your hypertension or your depression or your anxiety or your schizophrenia, you've come to the right place. Whether it's you need a job or you need a house or you need help arranging income, you've come to the right place. That's what these things are, and they have a funding stream that will be like the federally qualified health centers. So they won't have to, well, you know, God willing, creek don't rise, but they won't have to scrounge around for money like some of the agencies do at this point. So this project builds on the dual eligible project for people with Medicare and Medicaid, as well as the Health Home Initiative and the state innovation model to integrate mental health and primary care. The project will provide technical support and staff training to the centers that are part of this project, and a prospective payment system, which is this sort of new techno kind of thing, will be employed to pay for bundled care, which will mean that you won't have to they will count encounters, but they will pay by the episode of care, which means that they're paying for value rather than by the each for volume. And that holds the system accountable to do effective care, or at least that's the theory. And then the other IT piece is this big fancy IT system that not only documents that care was provided, but it also harnesses technology to identify innovation and inform the rapid learning cycle. So what role should NAMI play in this project? For starters, the planning process is guided by a steering committee. The steering committee exists, but the planning process requires that there be peer and family participation on the project steering committee, and that there be a peer and family advisory board at every regional center. And you can just bet that this area, Washtenaw County, will have one of these centers. So that there will be a peer advisory body at the center and a state advisory body. It's a lot of advising and a lot of meeting, I know, but if we get in on the ground floor, we can shape this system going forward. I've already heard some people in our meet and greet last night worrying about this. Is this going to serve us? Well, this is the moment to read the document. You can have my copy. As you can see, it's well worn already. I just downloaded it and I've been paging through it. But it's well worth reading, because our laundry list, our grocery list of what we need is in the plan. But a plan is only as good as its implementation. So we need to hold the system accountable to just do it. Our lives are on the line. Another planning process, the Governor's Behavioral Health and Wellness Council, convened in 2013. I think it was in the wake of the Newtown tragedy. NAMI really made a very distinct decision. That happened right, in December. It was a total shock to all of us that though all of those children were killed and that this young man was so troubled, and how did we get here? It spurred state legislatures in particular. Congress sat on its butt for a couple of years, but the state legislatures in particular and governors got active at that point. So my guess is that the Governor's Behavioral Health and Wellness Council kind of came on that wave. They produced a thoughtful report with lofty goals. They divided into work groups, which you see up here, including education, employment of veterans, and housing and independent living, physical and mental health integration, public safety and recipient rights, which do go together, data collection and stigma reduction, which kind of don't go together. But anyway, the upshot is that they came up with a whole lot of recommendations. Most of those recommendations are still sitting on the shelf. A few were implemented. Those that were implemented were scantily funded. So we need to hold the system accountable, bring the plan back, and say, this is unfinished business. So we've got these two plans generated by the government, promises to us, the people, that we can hold policymakers accountable to. And to the degree that they actually fulfill the promise of these plans, we will all be better off. So now I'm going to drill down to a few strategies that are identified in the Behavioral Health and Wellness Commission report and the CCBP, well, boy, I can't say that. Anyway, the Certified Behavioral Health Clinic proposal. Michigan has pockets of good practice, but these strategies, if they were consistently available statewide, would get us a lot closer to an excellent mental health system. I'll describe each strategy and give examples of best practices from other states that Michigan could adapt. I'm going to begin with early identification and intervention for children. Mental illness starts young. Half of all cases by age 14. Even those that we don't actually perceive until high school later on. They started by age 14, 3/4 by age 24, and yet it takes 8 to 10 years at this point, right, before people get a diagnosis, and by that time, their life has slid into the ditch. Children who struggle with unidentified mental illness lose critical years in which to learn developmental and social skills. Once the opportunity is missed, it's hard to catch up. Early intervention catches problems while they're easier to treat before they become too complex and ingrained. The American Academy of Pediatrics made a commitment to mental health. AAP asks all 62,000 of its members, pediatricians across the nation, to conduct mental health screening as part of every well-child checkup. The organization developed a toolkit with a series of quick, developmentally appropriate screening tools and advice for working with the mental health community to connect children to the services that they need. But identification is not enough. Children must actually get the array of services that can help them, that science has shown will help them thrive and achieve their potential. Medicaid requires early identification and intervention through a provision of the law called Early Periodic Screening, Diagnosis, and Treatment, which also, say that 6 times fast, that's really all these federal acronyms. Gee whiz. States are required to reach out to Medicaid eligible and enrolled families and provide early mental health screening, and that includes families in Medicaid expansion or the Healthy Michigan Plan. And EPSDT also requires states to provide all mental health services and supports medically necessary to ameliorate a mental health condition, whether or not they're included in the state plan amendment. How many of you in this room care for a child who lives with a mental illness? Anybody in this room? We do have some people. How many of you have felt totally confused and angry? I'm going to raise my hand. Because even with my decades of experience in NAMI, when Roger got sick at the age of 3, or when it emerged at the age of 3, I was thrown for a loop. I had to look around, I had to find social workers, I had to find people to help me coordinate care, and I'm a professional. So, you're among friends, let's just say it that way. But the state, we have to hold the state accountable to provide the care that our children need, the right care at the right time. Many states are not following EPSDT, the EPSDT mandate, or certainly not following it completely. So we can look to Massachusetts, where they had a class action lawsuit, an exemplary class action lawsuit called the Rosie D case. And you can go on rosied.org and see what they did. And Massachusetts, which, it's a well-heeled state, but they really leaned in. And they've got EPSDT, they've got the model of EPSDT that we can point to and we can adapt. Now let's look at schools, which are uniquely positioned to help identify students experiencing the early warning signs of emerging mental illness. Why? Because teachers and school social workers and guidance counselors observe children in class, in the hallways, and at recess. They see students struggling to get through the day. The changes in behavior and mood and school performance and social interaction associated with emerging mental illness are often visible, especially to educational professionals who know what kids look like and know how kids act. School counselors and psychologists play a key role in working with teachers to identify students, coordinate services, and work with families. But we don't have nearly enough of them, and many school-based mental health professionals have limited experience with delivering effective clinical interventions to kids who have the most serious issues. So Minnesota has developed a model called school-linked mental health, in which schools contract with community mental health centers. So the schools don't have to hire the clinical staff. They can titrate the clinical staff according to their need. And the clinical staff from the mental health center essentially just set up a little mental health clinic in the school, and the kids can come in during the school day, like you do for speech or for, some of these other kind of auxiliary health services. They basically embed the community mental health center in the school. This has several advantages. First, it provides a flexible workforce with expertise in treating children with the most serious mental health needs. And then while on site at the school, mental health clinicians can advise teachers who need help managing our children in the classroom. Second, the treatment records are kept by the mental health provider, not by the school. This allows the health information privacy and gives families a sense of safety. Families are often worried, are we going to get retaliated against because of the mental health problems of my child? And third, it's far more convenient for families who would otherwise have to miss hours and hours of work transporting their children back and forth to appointments. So the bottom line is that school-linked mental health services greatly improve adherence. So Minnesota, which instituted this model at first in, I think, 2007, has served 18,000 children. And they went from a little grant of $30,000 to $9.8 million this past year because it's been so effective. And now they're taking this same model and embedding it in juvenile justice facilities. We know that 70% of the kids in juvenile justice facilities have a mental health problem, and yet no services are delivered there. So they're just importing the community mental health center periodically into, like several times a week, into the juvenile justice facility. So now let's look at first episode psychosis. Mark talked about this. He talked about the RAISE study. He talked about University of Michigan right here in Ann Arbor having a site. And in fact, NAMI has given an award, a fellowship award, a award with money behind it, to a fellow right here in Ann Arbor to study first episode psychosis. And what this young person will start in next summer and will be supervised by Dr. Stephen Taylor. Does anybody know him? Yeah, okay. And so...
We'll be part of our Ask the Doctor panel.
Oh, yes! Oh, good. I'm going to be a fangirl. Okay, that's great. So the FEP programs use an array of coordinated interventions that are based on a strong international body of research. It actually emerged out of Australia. But Europe has done it, we've done it, Asia's done it. It's really an international body of research, and it works across cultures, across geography, all over the world. They help young people recover and stay on track in school and find employment and maintain connections with family, friends, and the community. So this is what all of us who have adult children, I have a nephew who struggles with schizoaffective disorder, and his life has been derailed, like the lives of many of yours. But had he been able to maintain that treatment, I'm not going to tell that story right now. It's a very sad but with a hopeful ending. Had he been able to maintain that treatment, his life would have been stayed on track. He would have finished college. He would have stayed married. He would have gotten employed. And he would be a happy and productive citizen. Well, maybe not always happy. None of us are always happy. But he would have been a productive and fulfilled citizen right now instead of having been homeless and in and out of jails. The evidence for this coordinated array of services is so strong that for the past 2 years, Congress has required states to set aside 5% of their mental health block grant for FEP. We call them first episode psychosis services. So if you hear FEP, that's what we're talking about. And most of these FEP interventions are not rocket science. They're simply common sense approaches that should be provided to anyone with a significant mental health need. But we've learned from Oregon, where they've implemented these services statewide for a decade, that when young people and their families have access to this service array in a coordinated fashion, the results are dramatic. It's based on shared decision-making with the young person. That's the fundamental principle of FEP. They don't use a bunch of medical terminology. They don't say, you have a lifelong illness and you're going to have to take medication for the rest of your life. What they say is, we want to help you live as good a life as possible. What do you want? Do you want friends? Do you want a nice place to live? Do you want opportunities to pursue art or music? What do you want? And they wrap those services around what the young person wants. And then they fold the family inside the circle. How many of you have experienced, as a result of HIPAA and confidentiality laws being written outside the circle? Right? Isn't that enraging? Well, FEP draws families in. It draws the circle around the whole family. So along with that, with outreach on identification and peer support, they do supported education and employment. They do case management. They do cognitive behavioral therapy, which we didn't used to think would help people with schizophrenia. But actually it does. It's very effective, particularly when couched in this array. And then when this array of services is made available at the right, the right place and the right time, the doses of antipsychotic medication can be much lower. So you don't have all the big bad problems, the weight gain and all the other problems that you have with these antipsychotic medications. So if scaled up and implemented faithfully, the array of evidence-based early psychosis services can change the trajectory of young lives. And even more significantly, if this coordinated array of services becomes the norm, we can ultimately write the course for the nation's mental health system. So we all want to find the handle. FEP is the way in to transforming the mental health system over time. That's what we at NAMI think. We recently, just last week, held a congressional hearing in which we rolled out the results of the RAISE study, a multi-site study across the country. Congressional members came, listened. We're hoping that they will maintain the 5% block grant set aside going forward and do whatever they can to ensure that these young people get the right services at the right time and that we remain faithful to them as they progress through their lives. Crisis services. So when I was reading up on mental health services in Michigan, it seemed like there were good crisis services in a few places and then a bunch of gaps in other places. Is that true? Yeah. So let's see. Tell me about the crisis response services in Washtenaw County. Give me a thumbs up if they're fabulous, a thumbs sideways, or thumbs down if you think they stink. Okay. Everybody, thumbs up, thumbs sideways, or thumbs down. Okay, we got a lot of sideways. So that we've got room for improvement. Okay. A comprehensive coordinated crisis response system should consist of 24/7 telephone crisis line, mobile crisis response personnel, and law enforcement working together. Law enforcement trained in CIT so they know how to de-escalate and how to connect with people in a sensitive and effective way. We need walk-in clinics and respite services. The respite services can be like respite services in a private home where people take in people in respite. They can be peer respite services. There was, in Vancouver, British Columbia, young woman, there was a peer respite center where everybody there had lived experience of mental illness. And they were wonderful. And they really helped people de-escalate. It was a lot better than being in the ER. And then, then there needs to be linkage to services. So the key is to establish the 24/7 crisis stabilization units. Do you all have a CSU or a crisis emergency, psychiatric emergency room in Washtenaw County? You do? Okay, yeah. So those have been a real game changer in the crisis response system because they're close to home, they're small, and because they're 16 beds or less, they're reimbursable by Medicaid, so that means the state saves a bundle of money, and people don't end up going to the state psychiatric hospital, but they get the expertise that they need. If you've ever been in an emergency room, a regular hospital emergency room, you know that they don't have mental health expertise. And so they're here sitting for hours and hours and hours because you've been triaged down, with the people with the broken legs and the heart attacks, and you're getting more and more anxious and upset, and you're endangering yourself and endangering the people around you, and they don't know how to deal with you. The staff doesn't know how to deal with you. So the CSUs resolve a lot of those issues. And they also help people get the help they need close to home and then get back out on with their lives. So Texas, which is not known for funding its mental health services, did a whole crisis system redesign in 2009. And they reaped all kinds of financial awards. So they made the business case because their policymakers were all about the bottom line. They said this is the right thing to do, but it's also the smart thing to do. So they got a 175% rate of return for every dollar invested in crisis redesign. And Colorado recently took a page, in the wake of Aurora and all of those horrible things, recently took a page from Texas, and they're in the middle of a crisis system redesign. But I want to point to a practice in Georgia, the Georgia Crisis and Access Line, which is really taking this into the new millennium. They have a electronic, real-time service tracking system where they track all the available services in the area in a dashboard. And so the crisis workers have this dashboard on their little iPad. They're going out in the community and they're going, okay, they're interviewing people and they've got all these tips on their little iPad, everything, decision trees and all that kind of stuff. And they're working with the person and they can find out right then and there from their handheld what services are available. And with this system, they have been able to get people, they've been able to cut in half the crisis response time, the connection to services time, and getting people close to home. So they've gotten quicker, more appropriate, more close to home services. And because it's electronic and Big Brother's watching, the state has data, they have performance data, so they got it right away. So that's something that you all should kind of take a look at. It's called BH Link. So next I'm going to talk about strategies to increase mental health workforce capacity. I'm not going to go through these in detail, but we have a crying workforce shortage here in Michigan and nationwide. The use of telepsychiatry is one strategy that's absolutely exploding. 24 states have telehealth parity laws, meaning that you can have parity between face-to-face mental health treatment, face-to-face mental health treatment and telehealth mental health treatment or primary care treatment. And Medicaid reimburses for telepsychiatry in 41 states. These bundled payment innovations that I was talking about earlier that are part of the Certified Community Behavioral Health program can bundle telepsychiatry into kind of the whole episode of care. So telepsychiatry is a way to get expertise out into the community and not requiring the person to come in. It's not good for everything. It's a different scope of practice, and we at NAMI want the whole telepsychiatry world to tool up. We want practitioners to have to get certification, training and certification in telepsychiatry. We want research to know how to do it right. This is an emerging field that will evolve over time, but we think it has immense potential. The other trend that we're seeing is the use of allied professions. So if psychiatrists, it takes about 13 years, I think, to hatch a child and adolescent psychiatrist. It takes 8 to 10 years to hatch a psychiatrist. Social workers, you've got 6 years anyway of schooling and practicums on top of that. So it takes a long time to get the mental health workforce tooled up, and I told you about that crying need. So one of the principles that states are increasingly using is to allow practitioners to practice to the ceiling of their licensure. So we're getting advanced practice registered nurses prescribing. We're getting social workers delivering therapy. We're getting licensed clinical counselors delivering therapy. And in the past, it has been very closely supervised, or at least supposed to be closely supervised by people with terminal degrees. But that tether is being loosened. So that's good and bad. We at NAMI want to insist that any of these allied professions that are prescribing psychiatric medications in particular have intensive training and supervision, until they got it right, and that there be some medications that are off the table. They're just too dangerous, that the APRNs should not be able to prescribe those. So we'll see how it goes, but it is a promising strategy, particularly out in the rural areas. Peer support specialists and beginningly family navigators are the boots on the ground, providing the quality time, the development of trust, the person to walk with you that is necessary for most people who are walking through the journey to recovery. So peer supports is now reimbursed by Medicaid in most states. Very few states don't. Only a few states, but a few states do. Medicaid reimburses family support specialists in a few states. It's not part of the federal Medicaid law, but it's reinvestment funds that are used by managed care companies. They reinvest and they pay for family support services. In Utah, they have a practice where they have a peer person and a family person in the hospital. So the person will go to the ER if somebody with a mental health problem arrives in the ER, or they'll help with discharge planning, and they will connect the person. Number one, listen to the person. Number two, connect the person with NAMI and with the other resources they need in the community. Integrated primary and mental health care is burgeoning. That's part of this whole project. It's really good, and what we at NAMI want is we want people who go to their primary care doctor or go to their federally qualified health clinic to be able to get routine mental health care for depression or for anxiety or for, all of those sorts of things. But once it gets into the deep end, we want strong collaborative relationships. We want psychiatric consultation from the community behavioral health system to the primary care physician in order to not overprescribe medication, because we find that well over half the psychiatric medication is prescribed by primary care physicians, but they tend to err on the side of caution, which means that they prescribe too much, not too little. And so psychiatric consultation can help them finesse. What do we need? You know, what dosage do we need? And help them kind of pinpoint the problem. Experts, so that's the expert consultation. Family education and support. We haven't tooted our horn enough, y'all. I'm just going to say. And so Mary Giliberti is all about this. She wants us to go to Congress, to get allocations from Congress like we're beginning to get for mental health first aid, for family education and support, because we know from personal experience how critical we are to families and peers. To have somebody who can stand in front of you is not disintegrated like I am at the point when I first reach out to NAMI and can walk and chew gum at the same time and say, yes, there's a name for this, there's something we could do about it, you can help, you know, you're not the problem, you're part of the solution, let's all work together. You know, that's transformative. That's such a deep relief. And we need to have much more family support and education out there. And then finally, fellowships and student loan forgiveness. We just need to crank them out, boys. You know, we really need we need to recruit people from underserved communities, whether they're ethnic or rural or veterans or, you know, whatever. Recruit people from those communities, help them get through school, forgive their loans in a return for a period of service with their home community. And we find that's the best practice. We find that if people come out of the community and they're trained and they're invested in the culture that they came from, and they'll stay over the long haul. Couple more things. Supportive housing. A decent affordable housing is fundamental to recovery. If you think about it, you just can't do it if you're not feeling safe. If you wake up in the morning, you're not feeling safe. That's not good for anybody's mental health, much less somebody who's living with a serious mental illness. But without subsidies, housing is out of reach for people on fixed incomes. In 2014, in Michigan, a person with a disability receiving SSI benefits equal to $735 a month. So with that income, it costs 111% of your income to get a one-bedroom apartment in Ann Arbor, right? Is that a workable solution? No. So we need subsidies. And I'm just putting up from my own state of Tennessee. Tennessee realized millions of HUD dollars were remaining on the table each year. And HUD has a process of community organizing, gathering the community together in order to do affordable housing. So they leaned into that, but then they did something that they called the Creating Homes Initiative, where they had regional housing coordinators who would reach out to realtors and bankers and get private investment to partner with the HUD funding. And they built or developed housing, decent affordable housing, along the continuum from 24/7 supervised to home ownership. And since 2001, when this program was first implemented, they've done over 10,000 units of housing. They have peer navigators who help people, you know, manage their housing, stay in housing, deal with the neighbors, deal with the budget, deal with the house cleaning. And this really works. So this is an evidence-based practice that I recommend. Supported employment. Everybody, the research shows that most people with serious mental illness want to work and would work if they got the supports that they need. So, but with Medicaid expansion, a major barrier to employment has been removed. Because what used to happen was somebody would say, okay, I'm well, I need to go back to work, but I can't work full time yet, so I'm going to work part-time. So they start working part-time and they earn just enough to get a nastygram from the Social Security Administration saying your benefits are going to be cut off. So not only are my cash benefits going to be cut off, but my medical benefits, those very medical benefits that have brought me to the point of recovery where I can work, are going to go away. So what happens? Either people go, okay, I got to quit, or they forge ahead and they say, well, I'm not that sick anyway, and then everything crashes. But with Medicaid expansion, you can go back to work part-time, you can keep your medical benefits. When you get to the point where you can go on an ACA plan, you can go on an ACA plan. And thanks to the Affordable Care Act, mental health is one of the 10 essential health benefits that must be provided to anyone with an individual or a small group plan. And it must be provided on par. So that the fact that we can keep medical benefits, as we have not been able to in the past, is a game changer for employment. So now we need to lean in with the employment supports, and I think we can really move that dial. So one of the evidence-based practices is called individual placement and support. Again, it's not rocket science, it's getting together with the person going, what do you want to do in life? And helping them kind of walk that back into where you are now, what steps can I take to help you get forward? Who do you want to work for? Who do you want to work with? Helping the person get that, and then coordinating their mental health care so they don't have to leave the job in the middle of the day to go to their clinic appointment. Or they don't have medications that are going to make it so that they can't actually get to work until 11 o'clock in the morning. So with IPS, Minnesota enjoyed such robust success that they recently codified IPS into practice, into state statute. And they granted $2.5 million annually in 2014 and 2015, specifically devoted to individual placement and support. And now the deep end that Mark cares so deeply about and I care so deeply about. But I'm going to say that it is a national disgrace that we tacitly allow the criminal justice system to pick up the slack as our mental health system erodes. That is completely unacceptable. When we look back 20 years from now, hopefully only 20 years from now, maybe 40 years from now, we're going to think this was barbaric. But to give them credit, the criminal justice system has stepped forward. We have our valiant CIT officers who have leaned in 40 hours of training and all of this, continuing education in order to make a sensitive, effective contact with people who live with mental illness and to get the help they need. But in order to get the help they need some place to take people, and they need services that the people can get into to help them. It's really distressing for cops who are very pragmatic people to go, okay, I can be sensitive all I like, but if I can't get the treatment, I'm going to see them again next week out on the streets, right? Deeply frustrating. And we applaud mental health courts, your wonderful mental health court here, that has taken people who have hit bottom and instead of punishing them, gone, okay, what do you need? And done some really good case planning with them. The judge holds them accountable, but the judge also holds the mental health system accountable to deliver the services that the person needs. And as a result of the mental health court, lives are transformed. And yet, the number of people with mental illness in U.S. jails has reached a crisis level, 2 million per year. Approximately 15% of men and 30% of women in local jails have a serious mental illness. People who deal with this problem every day agree that the current approach does nothing to improve public safety. It stresses already strained budgets and hurts people with mental illness and their loved ones. So recognizing the critical role that local and state stakeholders play in supporting change, the National Association of Counties, the Council of State Governments, the American Psychiatric Association, and NAMI, and a whole raft of other mental health stakeholder organizations have come together in an initiative called Stepping Up. Stepping Up asks counties to commit to developing an actionable plan. So it has the county design their own plan that suits their own situation, that makes more efficient use of budgets and promotes access to treatment and support services, encourages research-based practices, and supports the use of jails to advance public safety, not as psychiatric hospitals. Come on, guys. So, and Stepping Up realizes that counties need to partner with state government. So it also holds state government accountable to do what it takes, to arrange the policies, to do what it takes in order to fund the services that would help people stay out of jail and stay involved productively in their communities. So you've got the website on here, right? No, I don't. It's called www.stepuptogether.org. So take a look at it. They've got, is it on there? Okay, oh, there we go. Okay, good. And hashtag, since we're all new and modern and stuff like that. So this is, NAMI has really taken this on. We're urging our grassroots members to go to their county government. We happen to have our county government right in the room. It's fabulous. And to really move forward with this initiative, because we think that with all of these other things, we can change this story, this tragic story, where people end up in the criminal justice system with a record because of inadequately treated mental illness. It won't work for everybody, but it'll certainly work for a lot more people than it's working for now. I am at the end of my time, right? So I'm just going to say, right now, Congress, like I said, has finally sat up and smelled the coffee. There is a congressional member, Tim Murphy from Pennsylvania, who introduced a bill called the Families and Mental Health Crisis Act in 2013. The bill had a lot of wonderful stuff in it and a few things that really alarmed a lot of the mental health community. The new bill, introduced in 2015, has taken a lot of that feedback. It still has some things that make people nervous, but it's a much more enactable bill. On the Senate side, confusingly, there's a Senator Murphy, Chris Murphy from Connecticut, who has introduced the Senate version, the Mental Health Reform Act of 2015. And it has a lot of the same provisions. So these are parallel bills. It doesn't have any of the things that upset people. And it also leans more into enforcing mental health parity and first episode psychosis and that kind of thing. So the upshot is that we need Congress to pass these bills. This is going to be a long process. Passing a bill through Congress is a long, drawn-out process. These bills will change. They'll come together. A lot of the things that upset people will be changed. And I think what will come out of it will be much stronger, and we'll have a stronger funding stream and better coordination of services than we do right now. So it's kind of the gateway to the future. So Bob Nassar asked me last night for a good primary source for information on federal legislation. And I'm very proud to say that the NAMI policy team is second to none. It's on the inside track working with congressional staff daily to negotiate legislation in Congress. So Andrew Sperling, our federal lobbyist, is one of the most respected lobbyists in the mental health field in Congress. Ron Honberg and Laura Usher work on criminal justice. They're in there helping to write the bills. Darcy Grudadaro works on children and youth and young adult legislation. And Dr. Ingrid Herrera-Yee works on military and veterans affairs. So when we send out alerts, we're speaking from the inside the Beltway. So please respond. What we say in NAMI is, if you've got time to brush your teeth, you've got time to contact Congress. So just do it. And we've got it set up. We've got this easy peasy website. You look up there, and you've got information, you've got messages that you can shape to suit your own, or you can just press the button and it goes to your congressman. So the upshot is that we have an important voice. We need to use that voice. We need to stand up. We need to speak. We need to lean in. We need to get to know our policymakers, these new people who are coming on board. And after every election, march down to the district office and introduce yourself to your state legislator. Say, I'm from NAMI. We're the people who live with mental illness, and we're here to help. And by doing that, we will get on the inside track, whether we're here in Ann Arbor, whether we're in Lansing, or whether we're in Washington, D.C. So my friends, the stakes are high. We have much to lose, but we also have much to gain. So with that, what I'd like to do is just end. Do we have any time for questions, or we're just going to have to scoot out the door, Tyrone? Tyrone's looking at his watch. That's a bad sign. Okay. Well, here's Roger Deal. This is my son on a Michigan river.